we talked earlier about payers and the need for evidence. This was a big decision for CMS to decide that they were going to go ahead and pay for this. It's not a decision that has not been uncontroversial. Any thoughts? Will other payers follow, or?
Sure. It obviously is a huge decision. Any decision by CMS, whatever cost there is, has to be multiplied by millions. And so this becomes a very expensive type of project very quickly. But clearly the data was highly suggestive that this would be a wise thing to do, that in the overall scheme, not only would it obviously lead to better care and better health outcomes, the best way to treat diabetes is to prevent it from developing in the first place, but also in the long term that this would be a financial success. One of the advantages that CMS has is that folks, once they're on Medicare, stick with Medicare until the day they pass away. For payers in the commercial space, clearly this was a decision that was looked at quite extensively. Some payers have already made decisions regarding continuing coverage or providing coverage similar to CMS. My company is among those that have. Not everybody yet has, and some will be looking at the type of data that comes out in a real world, real life experience to see if the results that are hoped for are actually achieved.
I think another way to recognize this transformation over the last 10 years is to look at what the Office of Personnel Management has done for federal employees. So OPM sets the standards for health plans in terms of what the benefit package. And Aetna, all the large plans as well as a number of smaller plans. And over the last years, they've been very much more specific on what you need to do for prevention. And this year, for the first time, in the letter that goes out to all plans that describes to them what they need to do, they specifically call out diabetes prevention program as well as other things for people with diabetes as a very high priority for them as a federal employer with 9 or 10 million beneficiaries or member or employees. That often sets the standard because the plans will want to meet the federal requirements so they can maintain federal programs, but that also means they offer them to their other patients. So that's another watershed event that's occurred over the last couple of years.
The other thing that I think highlights back to the YMCA study, that provided not only the evidence that this could work in a community setting, which I think was important to take, as we said, from a very structured environment to a less resource intensive, although certainly a structured program, but also what convinced CMS was the cost savings that were demonstrated in that study. And so now it's no longer theoretical, will it save money? They were able to demonstrate that it did, and that in essence was exactly what CMI was set up to do, to be able to do pilot studies that show cost savings or high value and then spread that more broadly. And I think this, in a sense, one of the better examples of how CMMI has been successful in driving that.
Estimating return on investment. Yeah, let's talk a little bit more about prevention. Mary Ann, I know as a diabetes educator, certainly you work with patients that are already diagnosed, but tell us a little bit about prevention and sort of the role for educators and others in working with patients, talking about prediabetes, talking about risk factors.
You know, I'm glad you asked that, Dr. Scanlon, because it's been frustrating for diabetes educators all across the country to get referrals from physicians like on this panel for diabetes self-management education, and yet the patients are sending us have prediabetes, and they don't qualify maybe for the coverage of prediabetes because the payer's not paying, and yet we're getting those people with pre. So now that CMS is going to pay, and Aetna and different companies, diabetes educators are, we feel it's been manna from heaven. And we're in a perfect role to include that in our clinical expertise. And the American Association of Diabetes Educators is now training the DPP lifestyle coaches. They have a recognized training program to train the coaches for the DPP, and they're focusing on the diabetes educator and locations that already have a self-management program. So it's an easy fit to include prevention with an existing self-management program run by diabetes educators. It's a perfect marriage.
I'd like to comment something that might be slightly controversial even. To me, when a person's blood sugar is fasting, whether it's 98 and they don't have prediabetes, it's 110 and they do, 130 and they have diabetes, isn't that important. If they're overweight and sedentary, they have risk factors for diabetes and other chronic conditions. They have high cholesterol, high blood pressure, arthritis, a range of different conditions. We need to help them to improve their life's trajectory, help them so that they don't add a new chronic condition every 3 to 5 years, as many people do, manage their multiple chronic conditions if they have it. And so, yes, it makes sense for the diabetes prevention program to focus on people with prediabetes, but lifestyle intervention is the first prescription for a person with type 2 diabetes if they are overweight and sedentary. And so a glucocentric requirement of eligibility for a program that we know helps people lose weight, become more active, and improve these other outcomes is a little too restrictive for me. I really think we should be thinking about individuals at risk for multiple chronic conditions and how to help them have a trajectory that makes it so they can have the health they need for the life they want, not necessarily change from prediabetes to diabetes, which they probably don't even know they have. Because 9 out of 10 people with prediabetes don't know that they have it.
Yeah.
So it's both practical and theoretical.
Right.
Well, it also offers an opportunity, because these programs will be out there and there'll be data available, that it allows payers or anybody who has access to the data to be able to look at the issue of beyond just glucose benefit or diabetes related benefit, but there are other benefits as well that are associated with obesity or with excess weight, whether this is joint issues, back issues, things that are clearly not glucose-centric, but still related to in the same population and has a significant deleterious
So we
effect.
and others have demonstrated that. For example, lower the rate of sleep apnea. We went from 5.7% in a comparison group to 1.6% in those who did our intervention called the Diabetes Prevention Program. That intervention, that improvement alone paid for 2/3 of the entire cost. And it wouldn't have been calculated if you only looked at the diabetes progression, which also happened. Cardiovascular disease, high cholesterol, high blood pressure, arthritis, sleep apnea. Those are expensive conditions. And if you can demonstrate, and I think if we have Aetna's help and others, we can look at those kinds of secondary outcomes to be able to show an even better return on investment and better improvement in health.